Good afternoon, ladies and gentlemen. This is a recorded lecture on paranasal sinuses, isolated from the cranium chapter, separated. It's embedded in the middle of the chapter. I've taken out and extracted the content, broken it up into component parts because it's a big chapter. Lots to digest. It's better if we take it piece by piece. So. This piece happens to deal with imaging the paranasal sinuses. All right, so our objective, same as always, we want to do a quick anatomy review of the paranasal sinuses. We're going to talk about the positions and the projections to radiographically demonstrate paranasal sinuses. We'll talk about general procedure considerations. And then I am going to show you some examples of paranasal sinus radiographs, kind of like I am going to build in the image critique to the end of this lecture. That's why the lecture is just a little bit longer than usual. And then we will follow up on this lecture, this recorded lecture, with laboratory demonstration and practice. So that will be in the in-person meeting. Okay, so jumping into our anatomy review of paranasal sinuses. First of all, break down that medical terminology word, paranasal. Para means around or about. All right, and so paranasal would be pertaining to things that are around the nose. Sinuses is just a cavity, so cavities around the nose is what paranasal sinuses means. So they are the air-filled cavities, and they're located in the frontal bones, the ethmoid bones, the sphenoid bone, and the maxillary bones. Now the nice thing is the names of the sinuses correspond to the names of the bones that they're found in. So we have, those are also the bones that I just named, frontal, ethmoid, sphenoid, and maxillary. Those are also the names of the sinuses. Okay, you have frontal sinuses just above your eyes, right behind your eyebrows, basically, at the bottom of your forehead. Ethmoid air cells, or ethmoid sinuses, are what you would call the middle of your nose, okay, the middle of your nasal cavity. Sphenoid sinuses lie posterior to your nasal cavity, so above your pharynx. And then maxillary sinuses, those are the ones between the frontal and the maxillary. Those are the ones that are constantly getting infected. More so the maxillary because they drain extra mucus from the nasal cavity, the central nasal cavity. Gravity fills when you have excess mucus, naturally dumps to the maxillary sinuses, so that's why maxillary sinuses are often infected first. They fill your cheekbones, so right underneath your eyes on both sides. Most of the sinuses are paired, not necessarily the sphenoid. Sometimes the sphenoid is just one singular cavity, sometimes it is paired. But all the other sinuses are paired, left and right side. Okay. Functions: serve as a resonating chamber for the voice. Yes, I know him. That is Luciano Pavarotti. He is a famous Italian opera singer. Go ahead, Google, YouTube. He will be shocked. You might actually start crying at the sound of his voice. That is how magnificent a opera singer he is. He is just captivating. Okay? You will definitely feel the emotion in his voice even if you don't understand the Italian words that he's singing, you will definitely feel the passion of his voice if you just YouTube. It will not be a waste of your time. Okay. Decrease the weight of the skull. I guess that's handy. It is a 10-pound brain bucket, and making it weigh less is an advantage. I mean, because you do have to you don't even think about that, but you do have to carry your head around. It's more obvious in babies because their head is about twice the size of their torso or their body. So the weight of the skull, and of course babies don't have sinuses, so go figure. The weight of the skull, you do have to carry your head around, and the sinuses having hollow pockets in your head makes it way less. Aid in warming and moisturizing inhaled air. Yes, all of your sinus cavities are lined with mucosal membranes. Those are specialized cells that produce mucus, and that's part of the respiratory system. The mucus traps pathogens, microbes, dust particles, spores, pollen, smoke particles, all sorts of things get trapped in the mucus. And the sinus cavities actually increase the surface area of those mucosal surfaces such that you can trap more particles. Okay? Act as shock absorbers in trauma. Yes, a force or pressure wave going through your head is going to be neutralized by the sinuses. That is, they're going to absorb some of the shock as that pressure wave rolls through your body. Possibly control the immune system. They do give us an advantage in the immune system. You might have noticed upper respiratory infections, for those of us who are reasonably healthy, are more common than lower respiratory infections. The function of the sinus cavity is to create a landing surface for those pathogens, such that, because if the sinus cavities weren't there, it might be possible that we inhale more pathogens and get them all the way down to the lungs, rather than trap them in our sinuses. So I do think that some of the function of the sinus cavity is related to the immune system. It just gives us an area to trap external pathogens that we might be breathing in and preventing them from getting to the lower respiratory system. So yes, I'll take a head cold and a little bit of sinusitis here and there rather than having pneumonia every year. Yeah, I'll definitely take the first one. Okay. So yeah, that's important. So your sinuses are important. And your sinuses can also be, because of the sinusitis, sinuses are also sometimes the sources of headache. So there's that. Now, development. I just stole this off the internet, so don't pay attention to the white arrows. I'm not sure what the white arrows are pointing at. The author, whoever posted this picture, was talking about something else, so disregard the white arrows. What I want to show you is this is a neonate skull. This is a newborn baby, and yeah, they don't have a frontal sinus. Okay, they do have, you can see the orbit and you can see the maxillary sinus, but the maxillary sinus is crowded with the shark teeth, right? But there is a maxillary sinus there. Maybe just the tiniest ethmoid and sphenoid sinuses, maybe not even a sphenoid sinus. That might be ethmoid sinuses, but definitely no frontal sinuses, okay? So maxillary sinuses are the only ones easily identifiable radiographically at birth. And I would say that is true based on this radiograph. I definitely don't see frontal sinuses. You don't get frontal sinuses fully developed until 6 or 7 years of age. That I know for a fact. That is a registered question too, and so I probably will make it a quiz question. Okay. So there's graphics and illustrations in the book. What I did with those is I magnified those and cropped them down to the specific sinus that we're talking about. So you're going to see this picture over and over again, but it's going to be cropped in different ways. So I isolate the sinus that I'm talking about. On this slide, I'm talking about the maxillary sinuses. They are right below your eyeballs, inside the cheekbones. If you get pressure there or pain, that's probably a buildup of mucus in the maxillary sinus, okay? You can use an inhalant like Afrin, or there's another one called X-Clear. If you get congested often, and a lot of these inhalants are just saline solutions or some type of non-toxic chemical dissolved in a saline solution. It's just an organic molecule, but when you aerosolize it, it kind of acts to reduce the viscosity of mucus. What does that mean? It means that if mucus gets thick, which is one of the precursors to a sinus infection, we know mucus dries out, especially in the wintertime. And as it gets thick and loses its water content, it doesn't flow as well. And so it kind of gets hung up. And then if it's carrying pathogens and it's not moving, and it's not, well, then that's basically the precursors for the formation of a colony. And that's how sinusitis starts. So the key to not getting sinusitis is to keep the mucus more liquidy and less congesty. The thickening of the mucus is what starts the problem. And some of these inhaled aerosols, like your Afrin, like your X-Clear, these are not endorsements, but these are products I use, but you do whatever you want. Also, the neti pot, where you're basically pushing warm salt water through your nose, that will also reduce the viscosity of mucus and have things starting to move through. And that really is the key. You want mucus to move. You don't want to hang out in one spot. Okay. So the maxillary sinuses are paired. You have a left and a right one. They're fairly symmetric. It says they're roughly pyramidal in shape, upside down pyramids, kind of, but they do have rounded corners. So no, it's not really a pyramid in the sense that it looks like a triangular prism. A pyramid with the corners sanded off. Yeah, that's the maxillary sinuses. Okay. And the opening for the maxillary sinuses is actually at the medial superior border of the maxillary sinuses. So you see where that other indicator is coming through to show you the green sinuses? I think that's the ethmoid sinuses. Right where that indicator line comes through, that's the opening and the connection back to the nasal cavity, is that superior medial border of the maxillary sinus. Okay. Your frontal sinuses. This is where you typically get your ice cream headache. Don't eat the ice cream too fast. The ice cream headache is actually a pressure differential created between your ethmoid sinuses and your frontal sinuses typically. Okay. Remember how they said they had warm, moist air? But if you eat ice cream and you eat it too fast and it touches the roof of your mouth cools off. And then the ethmoid sinuses, the air in the ethmoid sinuses starts to cool off as well. And then you get a temperature differential. So you kind of get like a storm front effect almost between your frontal sinuses and your ethmoid sinuses, because cold air contracts, warm air expands, and so it's a relativistic sensation between the cold air in your ethmoid sinuses, because you just ate ice cream really fast, and the warm still trapped in your frontal sinuses. And that differential in the temperature creates a differential in pressure, and then by that difference, relativistically, you feel pain in your frontal sinuses. Okay, so don't eat the ice cream too fast. Okay, slow down when you eat ice cream, or else you will get a sinus headache in your frontal sinuses. You got to let that cold be reabsorbed by your natural body heat. Let your ethmoids heat back up, and the way that you can do that is to slow down the eating of the ice cream. Okay, take your time with it. It's supposed to be enjoyable. The whole idea of ice cream is decadence. Why wouldn't you take your time with it? Why are you shoveling it down your gullet as fast as you can? Savor it, enjoy it. That's what it's for. That's its entire existence, is for human enjoyment. So stop eating your ice cream so fast. Okay. Your frontal sinuses are also paired, left and right. They could be different sizes, as you see in this diagram. It's also often varying frontal sinuses, and most sinuses also vary from person to person. I, for example, have cavernous frontal sinuses. You might also notice that my voice is very nasally. And that's because the sum total of the air moving through my sinus cavities is a bigger volume than the amount of air that I can push through my mouth. And so my voice sounds nasally because what I'm doing, your vocal cords only just resonate the air coming out of your throat and make it vibrate. It's a bigger acoustic chamber traveling through my nose than it is through my mouth, and so therefore I have a nasally voice. It's because I have cavernous sinuses. Okay, the volume of air that I can store in my nose and my paranasal sinuses is probably about 3 times what I can store in my mouth, and so therefore I have a nasally voice. Okay, I can actually feel the inside of my nose vibrate when I talk. That's how I know what I'm saying is true. Okay, I can feel with my voice, I can feel tremors inside my nose when I'm speaking. Okay. Vary greatly in size and shape. Yeah, some people's frontal sinuses are huge, some are very tiny. Sometimes the left side is bigger, sometimes the right side is bigger. They are not symmetric. Okay, some people don't have frontal sinuses. Oh, they're blessed. They can eat the ice cream as fast as their heart desires. Your sphenoid sinuses are paired. Okay, I got that one wrong. I thought there was only one sometimes. It does say normally, so I guess abnormally not paired, just a singular one. It is in the sphenoid bone. Often only one sinus develops, but never more than 2. See, one sinus, okay? So vary in size and shape, usually asymmetric, the left side bigger than the right side, or the right side bigger than the left side, okay? The sphenoid sinus usually doesn't contribute to the ice cream headache, and that's because of its position. It's right over top of the nasal oral pharynx, and so the ice cream doesn't linger in that location very much. The ice cream kind of lingers in your mouth a little bit, and so the roof of your mouth anteriorly cools off, but the back of your throat doesn't cool off as much because the ice cream is being swallowed. It doesn't spend a lot of time in your oral pharynx. Okay, so right below the sella turcica and extending between the dorsum and posterior ethmoids. Okay, so basically underneath the sella turcica, superior to the nasopharynx, and posterior to the ethmoid sinus bodies, or the ethmoid air cells, as they're often called. Okay. Here are ethmoid sinuses. Ethmoid sinuses are multi-chambered labyrinths. They're in nautilus shell shapes. There's an upper nautilus shell and then a lower nautilus shell. You can see them on CT scans of sinuses. You can see, they call them the concha. The ethmoid sinuses make up the nasal cavity. They also offer the connection pathways to the other sinuses. So the maxillary sinuses, the frontal sinuses, and the sphenoid sinuses all connect back to the ethmoid air cells or the ethmoid sinuses. Okay, it's a labyrinth and it's not a straight line path. Again, to increase the surface area inside the nose, so there's more available mucus to capture pathogens, irritants, smoke particles, dust, any other things that you might be inhaling. Watch yourself, the cops will get you. Okay, I built model cars and airplanes as a kid. I did get high while I was building those, but it's not like I stuck the tube of airplane glue up my nose. Don't do that. That's a bad idea. You're killing brain cells. You're making yourself stupider. Okay, let me pause this. I think some student wants me. Hang on just a second. Ladies and gentlemen, back from my break. Sorry about the phone ringing. That'll wrap up just a second. So technical considerations for the sinus series. You do need to, sinusitis manifests as an air fluid level pathology, and so upright positions are going to be more diagnostic than supine or prone positions, because you're going to be able to see that meniscus, that air fluid boundary, and that's a definitive positive radiographic sign for sinusitis. There should not be a meniscus air fluid level in the maxillary sinus. So if you see one on a sinus x-ray, it's definitely a diagnosis of sinusitis. Central ray should be horizontal, so don't, if you're trying to capture an air fluid level pathology, you can't, like if the patient can't quite get in the right position, you know how we sometimes say, let's adjust the tube to compensate for the lack of mobility, rotation, or obliquity, or what have you, of the patient or their body part. You can't do that with a sinus evaluation, because you do need that horizontal x-ray in order to get that air fluid level sign. So, of course, we should shield our patients. Must be used on pregnant patients and pediatric patients. You should be using shielding for all patients of childbearing age. The paranasal sinuses are nowhere near the reproductive organs. There's no reason not to shield people. Okay. Well-collimated radiation field will ensure optimal digital image quality at the lowest possible patient dose. You do want to trim in. The sinuses probably can be contained in a 6x6 or a 5x5 exposure field. You don't need the entire skull. If you get the entire skull, if you open the collimators to like 8x10 or 10x12, you're just producing more scatter radiation that is going to erode the contrast that you need to see the sinuses effectively. So the sinuses are a high contrast type study, very much like an extremity, and that contrast is sensitive, and if you open the collimators too wide, you don't get an effective evaluation of the sinuses. We should use small focal spots for better spatial resolution, and we should check to make sure, in particular, our PSP plates have been cleaned and free of artifact, because a lot of times what we're doing with a sinus evaluation or a facial bones evaluation is a pre-screen for MRI. I think there's a slide coming up where it shows a metal artifact in the orbit, and we'll be able to see that. That's either this one or one of the other lectures. I've been building a couple of these cranium chapter lectures, so maybe we'll see that coming up. All right. Oh yeah, look, there it is. See the arrow right there? So this is a Waters projection. Your essential projections for the sinuses are lateral. You're going to see all 4 sinuses on a lateral. Caldwell projection is going to show off the frontal sinuses and the ethmoid sinuses. Parietal acanthial Waters projection is going to best demonstrate your maxillary sinuses. Open mouth modification of the Waters is going to demonstrate the sphenoid sinus very well. And then submental vertex projection is going to demonstrate, again, all 4 sinuses. Maxillary sinuses are obscured by the teeth usually on an SMV. Ethmoid sinuses can be seen through the roof of the mouth. Sphenoid sinuses can definitely be seen on an SMV. Frontal sinuses sometimes obscured by the front teeth as well. So they say technically all the sinuses show up free of superimposition on an SMV, free of superimposition with each other, but if the patient has teeth, the teeth are in the way of both the maxillary and the frontal sinuses typically. Okay. So we're faced with a review question now. Only facial bones that contain paranasal sinuses. Remember, there's a difference between the bones of the skull, which house the brain, and the facial bones. Those are 2 separate groups of bones. All of the sinuses are in the bones of the skull, frontal, ethmoid, sphenoid, except for the maxillary sinuses, which is a true facial bone. So the maxillary sinuses contain paranasal sinuses of the facial bones. And it's an arbitrary divisor. It's the bones that surround the brain versus the bones that don't surround the brain. and the maxillary sinus is not a bone that surrounds the brain, so it's considered a facial bone rather than a skull bone. Okay. Technical considerations again. Oh, it looks like we got a repeat slide here, but I did provide you a picture. There's a nice upright waters projection for you. But same considerations. That small focal spot, I might have failed to mention, a lot of the bony structures in the ethmoid region and the maxillary, just in the facial bones in general, are small, really fine detail structures. And so to see them effectively, we need nice, sharp, crisp edges. So we do want a small focal spot. I skipped over that, but I did talk about dirt on the image receptor, particularly the PSP plates, the CR plates. Dirty image receptors can be mistaken for metal artifacts, and then a patient that needed an MRI would be ruled out against getting an MRI because you had a dirty cassette and it looked like there was metal embedded in their face, which would be a bad idea to send that individual into an MRI scanner. Okay. So our lateral projection, all four sinuses, there's our frontals up top, two orbits, and sandwiched in between the orbits are the ethmoid sinuses. You can see the posterior ethmoid sinuses. The anterior ones are kind of superimposed by the orbits. Sphenoid sinus, immediately inferior to the sola turcica. Superimposed left and right maxillary sinuses just above the upper teeth there. Okay. You get finer details and better edge detail with the side closest to the image receptor. So if they do have some kind of known pathology, let's say sinusitis, and it's the right side that's hurting, not their left, it's unilateral to the right maxillary region, you might want to swap out and do a right lateral rather than a left lateral, because that brings the right maxillary sinus closer to the image receptor and you get better recorded detail. So you will also be able to assess the thickness of the frontal bone, and you can see how deep the frontal sinus is, how big the maxillary, get an idea for how big the maxillary sinus is, and the sphenoid sinus is on these lateral radiographs. All right, in order to show position for lateral sinuses, okay, interpupillary line perpendicular to the image receptor plane. Okay, so the imaginary line drawn between the centers of their eyeballs is going to be perpendicular to the image receptor. Okay. Infraorbital meatal line oriented horizontally. So raise their chin just slightly until the lower edge of the orbit. Extend a line back to the hole in the ear. Bring that line horizontal, and you have their head elevated enough for lateral sinuses. Okay, and let's see if we can figure out central ray. 1/2 inch posterior, 1 to 1/2 inch posterior, 1/2 to 1 inch posterior to the outer canthus. Third time's the charm. All right, so just a little bit beyond. What is the outer canthus? Oh yeah, that's the corner, the outside corner of their eye, actually, where the eyelids meet, the lower eyelid and the upper eyelid meet in kind of a acute angle out here. That's the outer canthus, okay? So you can see from the side view, we want to go 1/2 to 1 inch posterior. Okay, should be approximately on the middle of the zygomatic arch, just like we see for lateral facial bones. Your exposure field should be 8 by 10 inches. You do not need the vertex of the head, nor do you need the mandible. You need the happy medium in between. So 8 by 10 should be that the 10 is the vertical dimension, the 8 is the horizontal dimension. So extend your collimation 5 inches superior to the outer canthus, 5 inches inferior to the outer canthus, and that should cover both the frontal sinus and maxillary sinus. Won't be clipped if you do that. So 1/2 to 1 inch beyond the tip of the nose. Superiorly to 3 inches above the nasion, inferiorly to the occlusal plane, posteriorly to the auricle, which is another name for the EAM. Okay. So you want to go beyond the tip of the nose because actually the nasal cavity, even in its cartilaginous form, in the proboscis, is part of the evaluation. Okay. Inferior to the occlusal plane, remember that that's the name of the bite plane. Okay. Superiorly 3 inches above the nasion. Remember, the nasion is the dip at the very top of your nose, where your nose meets your face. There's a little divot right there. Just before you get to your eyebrows, that divot is called the nasion. Okay. So 3 inches, open the collimations 3 inches above the nasion. That should cover even the largest frontal sinus. Okay. Your Caldwell method, now we're going to go to a PA projection, and you're going to see the frontal sinuses above the frontonasal suture. Okay. And so that relies on that 15-degree caudal angle to do that. You're going to see anterior ethmoid air cells, sphenoid sinuses through the nasal fossa below or between the ethmoids. So that's really hard to see because there's a middle concha and then an inferior concha, I believe, or a middle concha and a superior. I can't remember what the names of the concha are. But that lower concha at the base of the nose, that is producing a lot of artifact. Good luck seeing the sphenoid sinus on this projection, actually. Petrus pyramids in the lower third of the orbits, that's a sign that you have the tube angle and or the tipping of the head at the right degree of magnitude. Tube angles should be 15 degrees cauded. Orbital meatal line should be tipped 15 degrees superiorly at the outer canthus if you are not applying a tube angle. So either raise the chin 15 degrees or angle down 15 degrees. The choice is yours. Okay. You'll get a better distortion elongation effect if you use a tube angle. Okay. Back when we had dedicated head units, it was common for the Bucky tray to be tippable, like you see here. This is the ideal way to do a Caldwell method, perpendicular to a tipped image receptor that makes contact with the forehead and the tip of the nose, the nasion centered to that image receptor, central ray exiting the nasion. Horizontally, that's going to give us our best air fluid level sign. And then we want to raise the orbital meatal line from posterior to anterior, a 15-degree incline to that orbital meatal line. That's going to ensure that we, with the horizontal central ray, it's going to ensure that we get a good air fluid level sign if one is present. Okay. Angled grid technique, patient position is upright. Okay. Seated, upright facing the Bucky. Mid-sagittal plane, obviously centered to the midline of the image receptor. Don't let them rotate, so both the anterior and posterior mid-sagittal planes in the same line, perpendicular to that image receptor. Okay. If you don't have a tipped cassette, you can also use a shallow angle sponge to create the same effect. There will be some distortion. No, actually, distortion will be mitigated on this one. So there's elongation distortion on the previous one with the angled grid technique or angled image receptor technique. Okay. So our part position, again, upright, orbital meatal line, inclining, posterior to anterior, about 15 degrees out of horizontal, perpendicular central ray, directed horizontally to a vertical image receptor means we're going to see air fluid levels. Okay. Tilt vertical bucky down 15 degrees. Rest patient's forehead and nose on device. That's just a spacer sponge. Okay. Center the nation to the IR. Yes, for the Caldwell projection, the central ray always exits the nation. Okay. Mid-sagittal plane and orbital meatal line perpendicular to the IR plane. Okay. Doesn't look like the orbital meatal line is perpendicular to the IR plane. That's an error. Okay. Positions the patient's orbital meatal line at a 15-degree angle to a horizontal CR. So they just contradicted themselves with the last slide. Okay, this is the correct orbital meatal line on a 15-degree incline from the EAM up to the outer canthus of the eye. You should be at a upward slope going into the face. Okay. Nation centered to the IR, mid-sagittal plane perpendicular, both front and back, no rotation. Radiolucent support may be needed at the forehead. That's just so they don't waver in the breeze. Okay. Method not preferred because increased OID. Okay. So you get poorer visualization of the frontal sinuses in particular, because you have a gap in between the frontal sinuses and the image receptor. Okay. That angled grid or cassette technique takes care of that. Okay. So our Caldwell method, the central ray is directed horizontally. That's going to give us an air fluid level, which is a positive pathology on sinus studies. That central ray always exits the nasion. Center the IR and the central ray to the nasion. Okay, the nasion is the frame of reference. It is the center of the pertinent anatomy. Collimation, 8 by 10. Okay, I would say for a PA axial Caldwell, you can probably go 8 by 8. Okay, and that would be, if you do have a longer dimension, that would be portrait style. Okay, so open up top to bottom more than you do side to side. Okay. We're trying to see the frontal sinuses and the anterior ethmoid sinuses, both of which are centered to the midline, so you don't need a lot of room side to side. Honestly, for most folks, 6 inches of collimation side to side is going to be plenty. Okay. Radiation field to extend 1 inch beyond the lateral skin shadows. So basically the edge of their head on the image receptor or the vertical bucky. Inch superiorly. Gotta let that ring through. Hang on just a second. All right, getting back to it. Sorry about that. I think probably, yeah, for a Caldwell projection, we can go 6 inches across, 10 inches. 10 inches is even 6 by 8 probably fit most folks. You're going to, as you increase your field of view, your exposure field, you're going to increase the chance that you're producing scatter radiation, and that's going to adversely affect your subject contrast. So you got to be mindful of that. Okay. Lateral skin shadows, literally the side of the face. Superiorly to include just the shadow of the top of the head. Yeah, you don't need to go up that high. Okay, the frontal sinus, even the biggest frontal sinuses, you can go to the hairline and you're safe for most folks, or where the hairline should be. Okay, hopefully you're not x-raying Peyton Manning. Inferiorly to the occlusal plane, which again is the bite plane. If you're down at the bite plane, then you're definitely below the maxillary sinus. Okay. So here's our Waters projection. This is what it looks like. You're going to see your petrous pyramids. That is the most dense, that we talked about those in the skull unit. The most dense bones in the entire cranium, the entire head, are the petrous pyramids. And a lot of positioning is just getting them out of the way so they're not superimposing what it is you really want to see. In the case of the Waters projection, we really want to see the maxillary sinus, and so we have to tip the head back radically in order to get the petrous pyramids below the maxillary sinuses. You get a decent view of the zygomatic arches there too. I really like the zygomatic arches. Frontal and ethmoid sinuses will be foreshortened on this, and so you don't really get a good evaluation, especially the frontal sinuses do not evaluate well on the Waters method. Okay, so there is our Waters method. The OML is 37 degrees from the IR, which is how you answer the registry question. Now, how do you actually position this? You want the tip of the chin to the ear to be a perpendicular line. Okay, so the mental point, the mental meatal line, tip of the chin to the hole in the ear, to the EAM. Okay, that's going to be horizontal. So you're radically tipping the patient's head backwards, raising that chin up. But you don't center at the mental meatal line. You center exiting the acanthion, which is right at the base of the nose, where the nasal septum meets the upper lip. That's where the acanthion is. Okay. Horizontal central ray, again, is crucial for sinus evaluation. We don't want to deviate from the horizontal central ray because we will not be able to see air fluid levels without a horizontal central ray. Okay. 1 inch beyond lateral skin shadows, again, open up to include the sides of the face. If you can see a little bit of light on each side of the head, then that's good. Superiorly to just the shadow of the top of the head. Again, you want to go to about where their hairline should be, okay? Even though you don't want to clip the frontal sinus, even though it's not the best demonstration of the frontal sinus. Inferiorly, again, to the occlusal plane, and you are definitely below the maxillary sinus if you're at the bite plane, okay? The open mouth projection looks kind of weird, but it also looks kind of like a Waters. When you have them open their mouth, the top teeth, the teeth in the maxillary bone, actually move out of the way so you can see the sphenoid sinus posterior to the ethmoid sinuses. Okay. So petrous pyramids again lying inferior to the axillary floor, or maxillary floor rather. So the maxillary sinuses should be above the petrous pyramids. Really, this is just the same view you just did. You're just having the patient open their mouth when they do that. So again, now you'll see the mental, they say mental meatal line perpendicular, but if they open their mouth, it's not really perpendicular anymore. So better to go with the 37-degree incline, which is actually a 53-degree incline if you do the subtraction. From 53 from horizontal, 37 degrees from vertical. Okay, that's what the 37-degree angle is. Okay, so OML 37-degree angle to a vertical plane or the image receptor plane. When they have their mouth closed, the mental meatal line will be perpendicular, but as soon as they open their mouth, it actually ends up, that looks like about somewhere between 5 and 10 degrees downhill rather than perpendicular to the image receptor plane. So another error there, watch for that. Opening the mouth wide will reveal the sphenoid sinus that would have been superimposed by the teeth on the previous projection. Okay, again, we're exiting the acanthion, the base of the nose, right where the nasal septum meets the upper lip. Okay, a 10 by 12 field for this one, and down to the occlusal. You actually want to go below the occlusal plane because you're trying to capture the sphenoid sinus. So yet again, another error in our PowerPoint. Probably want to go all the way to the tip of the chin. Open the collimation down to the tip of the chin, and that way you're sure that you have the sphenoid sinus included. Okay. Our SMV projection, submento, mental point is the tip of the chin, so submental means If it's a projection, it means the central ray is entering underneath the tip of the chin, and then vertex is the top of the head. The central ray exits the top of the head. So you need the guy from the Reach toothbrush commercials that's got the flip top head. Your geriatric folks are definitely going to struggle with this thing. For the sinuses, it's not going to be as effective for you to do an adjustment angle with the x-ray tube like we would if we were doing facial bones or zygomatic arches, okay? Because we're evaluating sinuses, we want to keep a horizontal central ray. Okay, so the patient upright, and then hyperextend the neck and rest the vertex of the head on the vertical image receptor, okay? Most of your patients are not going to get all the way there. Continue to shoot for a sinus SMB, continue to shoot with a horizontal central ray. Do not adjust the angle to compensate for a lack of hyperextension on this version of the SMB. Okay. IOML should be parallel to the image receptor only if your patient is extremely flexible. Okay. So yeah, just like that, just put all your patients. Yeah, you can imagine your 80-year-old man getting into that. There ain't no way you're going to stretch an 80-year-old man's neck like that. You can't stretch my neck like that. I can't do it anymore. When I was first started teaching, I could demonstrate this. But now, 10 years down the road, I can't demonstrate this anymore. I've lost that amount of flexibility in my neck. So good luck with your geriatric patient. Okay. The central ray enters the mid-sagittal plane 3/4 of an inch anterior to the level of the EAM, okay, which should be, I mean, that's almost at the gonian, almost. It's real close to the gonian, which is the angle of the jaw, okay. Collimated field, 8x10, I think you can go 6x6, you'll be fine. 1/2 to 1 inch beyond the tip of the nose. Do include the nasal cavity in its entirety, and include the shadow of the lateral aspect of the head on both sides. Okay? Are you going to get all the way to the back of the skull? Probably not. Okay? But if you're centered at the gonian and you're extending collimation beyond the tip of the nose, you're going to get the frontal sinuses if you go beyond the tip of the nose, and you're going to get sphenoid sinuses if you're centered at the gonian. Which sinuses are best demonstrated on the parietal acanthial projection, the Waters method? And the answer is the maxillary sinuses, because the words best demonstrated have special meaning in the context of a credentialed question. Best demonstrated means the anatomy closest to the image receptor for whatever projection they name. And so of the choices here, the maxillary sinuses are definitely closest to the image receptor for a parietal acanthial projection. Which are best demonstrated on the Caldwell method. That would be the frontal sinuses have now moved. So the maxillary sinuses on the Waters method, frontal sinuses on the Caldwell method. And the frontal sinuses are, remember, for the Caldwell, the central ray exits the nasion, which is immediately inferior to the frontal sinuses. For the Waters, the central ray exits the acanthian, which is immediately inferior to the maxillary sinuses. So the central ray exit point, if you memorize those, that also gives you a clue as to best demonstration. You just have to think of the sinus cavity that's closest to the central ray exit point. And that's going to be your sharpest edge detail, because you have decreased OID for that particular part of the anatomy. All right, here's our lateral projection. This is the image critique, bonus image critique content. I'll try to get on, the problem is no one does any skull radiography anymore. So I'll try to get on the PACS and show you guys some representative examples of either sinus series or skull series, but exams are going to be few and far between. So A lot of times we got to rely on the reference images from the Merrill's Atlas, and maybe some from Radiopedia will help. But CT has really stolen this area of imaging the body, so we don't get a whole lot of exam volume in sinuses, facial bones, skull radiography, none of those. Okay. Closed beam restriction to the sinus area. Well, stop recommending that they open to an 8x10 then. In my practice, my experience, a 6x6 is usually more than enough for a sinus evaluation. Okay. All 4 sinus groups should be displayed on the lateral projection. You should see the sphenoidal sinus is best demonstrated on this compared to other views of the sinuses. This is the best way to visualize the sphenoid sinus. Okay, we're going to see the frontal portions of the ethmoid superimposed by both orbital cavities, but we'll still see ethmoid sinuses. We're going to see maxillary sinuses left and right superimposed, frontal sinuses left and right superimposed. Okay. No rotation or tilt. We know that there's no rotation or tilt because the cella turcica is going to be in profile. Superimposed orbital roofs or cranial floors, however you want to refer to those, and superimposed mandibular rami. You might notice that the evidence for no rotation for lateral sinus is the same as lateral facial bones, is the same as lateral skull. We should see bony trabecular detail in surrounding soft tissues, including the entire soft tissue cartilage of the nose. That's pertinent anatomy on a sinus evaluation. Okay, don't clip the nose. All right, for our Caldwell method, evidence of proper collimation. Okay, frontal sinuses lying above the frontal nasal suture, and anterior ethmoid sinuses lying above the petrous ridges. Okay. No rotation or tilt. And how do we tell? Equal distance between the lateral border of the skull and the lateral border of the orbits. And that's going to be an important sign for all of our PA skull work, not just for sinus series. Anytime we're doing a Caldwell or a Waters or even a Towns or a Haas, rotation side to side is, do we have symmetric orbits relative to the left side of the skull and the right side of the skull? Are the orbits closer on the left than they are on the right? Well, that indicates rotation. Okay, petrous ridges also symmetric. You have a left and right petrous ridge, and as the orbits shift position, so also will the petrous ridges appear to shift position. The petrous ridges will actually shift the opposite direction to the orbits, and that's because the pivot point, remember, is the dens of C2. Petrous ridges are posterior to that pivot point, so they'll shift in the opposite direction to indicate obliquity. Okay. Mid-sagittal plane of the head aligned with the long axis of the collimated field. Remember what I said about broken noses. We cannot use the perpendicular plate of the ethmoid bone or the nasal bones as a frame of reference to evaluate the mid-sagittal plane. Okay, those bones are supposed to be on the mid-sagittal plane, but a better alignment is Nasian, acanthian, mental point. Those things are meant to be on the mid-sagittal plane, and they don't suffer from deviation when you get into a fist fight. AJ, that use of the word deviation, that was for you, buddy. Okay. Caldwell method, here it is on display. Here's an example. So the frontal sinuses, very well demonstrated. We also can see the crista galli on the Caldwell projection. Sphenoidal sinus superimposed over the ethmoid air cells. Ethmoid air cells right in between the orbits. You will see portions of the maxillary sinus, but most of the maxillary sinus will be superimposed by those petrous pyramids. The petrous ridge, being the most superior part, is going to be 1/3 of the way up the orbit if you have the angle, tube angle or tipping of the head correct. Then you'll see petrous ridges in the lower third of the orbit for the Caldwell. Okay, lower third, bony trabeculi. You do want to see bony trabeculi surrounding soft tissue structures. Okay. For the Waters method, maxillary sinuses on display, free of superimposition by Petrus pyramids. If the Petrus pyramids are on top of the lower part of the maxillary sinuses, you didn't tip their head back far enough. Okay, so this is a proper tipping. We can see the Petrus pyramids are roughly at the occlusal plane down there and free of the maxillary sinuses. The patient also has accumulated fluid in the lower portions of the maxillary sinuses. So we can tell that this is upright because I can see bilateral menisci and opacities in the lower half of the maxillary sinus. This patient, not only is this a properly positioned Waters radiograph, it's diagnostic for sinusitis because we have a partially filled maxillary sinus bilateral. Okay. The maxillary sinuses symmetric. You should see that they are equidistant from the center and about the same size. One's not bigger than the other. They're roughly the same shape. You notice the orbit is kind of circular, but not exactly circular. Diameter of the orbit should be consistent from the left to the right. If the diameter of one grows and the other one shrinks, that's foreshortening, elongation, and you have rotation. Okay. For our SMV, for our open mouth Waters projection, it almost looks like an SMV. I guess it's getting closer to an SMV with the mouth open. You're going to see the sphenoid sinuses framed by the upper teeth, if they have upper teeth. This is Tennessee, after all. So evidence of proper collimation, bony trabeculi, soft tissue details. Sphenoid sinus, the whole point of doing another Waters view with the mouth open is to capture the sphenoid sinuses through the open mouth. So just check for that. They should be posterior to the ethmoid sinuses. And then the teeth do climb up into the maxillary sinuses just a little bit, those upper teeth do. So you won't see the maxillary sinuses as well as you would on a closed mouth Waters. Okay. And then we want the Petrus pyramids far inferior to all these structures. They should be coming in right around where the molars are on the maxillary bone, but they could be lower than that. Right? No rotation or tilt, mid-sagittal plane in alignment with the image receptor. Okay? You'll see the acanthion, the nasion, you'll see the mental point all lined up. Remember that the meniscus, the soft tissue cartilage, and the nasal bones themselves can become deviated from the mid-sagittal plane, and they're not an accurate indicator of the mid-sagittal plane. Orbits and maxillary sinuses, symmetric on each side. Again, left one should look exactly like the right one. Okay. Moving right along, here's our SMV projection. We're going to see best demonstration of ethmoid air cells free of superimposition. Really nothing in the way here. You go straight through the roof of the mouth and bang, there they are. We don't have to worry about, typically ethmoid air cells are superimposed by sphenoid air cells, and so no, the sphenoid air cells are posterior, and so you won't see them on top of the ethmoids. Ethmoids are going to be at the top of the image receptor, which is actually the anterior aspect. Yeah, those molars are going to get in the way of the maxillary sinuses. You can see a portion of the maxillary sinuses, but lots of superimposition by the jawbone over maxillary sinuses. And then the front teeth, the incisors and the canines, are going to obscure the frontal sinus. So not good visualization of frontal and maxillary sinuses, but very good visualization of ethmoid and sphenoid sinuses. And if you're really good, you can also get a top-down view of the dens and the vertebral foramen, which you'll see at the bottom of that radiograph there. Too bad it's not labeled. That would be great to label that. I hope you can make out the dens of C2 right there. Okay, yeah, it's the little circle at the front of the big black circle. The black circle is the vertebral foramen housing the spinal cord. Okay. So centering for this, remember we want to do mid-sagittal plane, and it said 3/4 of an inch anterior to the EAM, which you can see on either side there. That puts you right at the end of the vomer and the bony perpendicular plate. Okay. IOML parallel to the IR, yeah, good luck. Okay. That is sufficient neck extension. No, it's not extension, it's hyperextension. Okay. Basically, your instructions are have them step, have them with their back to the board, have them step away about 6 inches, 6 to 8 inches, and then tell them to tip their head back till they're looking at the ceiling. That's your best that you're going to do. Recognize that some people are not going to have that amount of flexibility, but you still should not deviate from a horizontal central ray while you're doing sinus. If you're doing facial bones, yes, absolutely compensate for a canted IOML with a compensatory, typically cephalad angle 5 to 10 degrees. Okay. Mandibular condyles anterior to petrous pyramids, bony trabecular detail, and surrounding soft tissues. All right, which sinuses are those? Yeah, sometimes the questions are easy. This is the frontal sinus. Okay, and then which sinuses are demonstrated, not best demonstrated, but just demonstrated. And the answer is all of those. We do see portions of the maxillary sinuses, the best demonstration of the frontal sinuses, and we do see the anterior ethmoid sinuses on this as well. So all three are demonstrated maxillary, not well demonstrated, partially superimposed by petrous pyramids. Okay. And then this projection is a modification to demonstrate. What's a modification of? That's a modified waters with an open mouth, and it's to demonstrate sphenoid sinuses. Okay. That's all I have for you regarding paranasal sinuses, and we will do a positioning lab on that shortly. I am about 2 weeks ahead with the recording, so I'm not sure of the specific date. So I will see you guys later. Oh, look, I kept it right at 1 hour. How about that? That's fantastic.